يسعدنا ان احنا نبتدي اول سيشن النهارده يوم الخميس. السيشنز على الارثروبلاستي including طبعا hips and knees. يشرفنا وجود الدكتور حسن عبد الحميد عبد الفتاح من مصر. هيكلمنا على subtrochanteric varus osteotomy versus total hip arthroplasty in moderate and advanced hip osteoarthritis in young adults. And المشكله ديت كانت كتب عليها كتير بومبلي على الفالجاس فليكشن اوستيوتومي وكذلك باول. يا ترى ايه الجديد يا دكتور حسن؟ اتفضل. يا ريت بس قبل الدكتور حسن ما يبتدي نحط التليفونات على سايلنت including the WhatsApp notifications لانها disruptive. في نفس الوقت لو حد عايز يصور حاجه يطفي الفلاش بتاع الكاميرا لانه بيزغلل اللي قدامه. شكرا جزيلا.
Good morning, everyone. Our study is a retrospective comparative study between subtrochanteric valgus osteotomy versus total hip arthroplasty in moderate and advanced hip osteoarthritis in young adults, which is considered old technique revisited. Before we start, special acknowledgement for Professor Dr. Khalid Amara, who is the principal contributor and the main surgeon in the operations. Special acknowledgement for Professor Rami Ahmed Diab, and special acknowledgement for other doctors who shared in this study. Subtrochanteric valgus osteotomy is often described as forgotten procedure in the management of hip osteoarthritis. The aim of this study is to compare the outcomes of subtrochanteric valgus osteotomy in young patients with moderate and severe hip osteoarthritis. Why osteotomy? Because there is a high revision rates associated with total hip arthroplasty in high demand young individuals. Also, the financial burden of both primary and revision arthroplasty. We will talk about this in the next slide. Also, the non-activity restrictions related to total hip arthroplasty. About the financial burden, there was found that hip revision arthroplasty has the highest average cost among arthroplasties, with average cost between $18,000 to $19,000. Even primary total hip has an average cost between $14,000 to $15,000. How osteotomy work? It acts by redistribution of joint loads away from the degenerated cartilage. Also, it has a role in improvement of joint congruity, especially in cases of secondary hip osteoarthritis, which may be associated with hip deformity like post-bursitis, post-DDH, when the joint is incongruent. So the osteotomy help to increase the joint congruity. Also, it helps in reduction of intraosseous venous pressure and enhancement of femoral head vascularity through the osteotomy. It also improves the hip and the back pain through improvement of the pelvic balance and the limb length discrepancy. We have obtained the ethical approval from the ethical committee at our university, Ain Shams University. Only symptomatic patients were included in the study between 20 and 45 years old. Patients with previous hip or pelvic surgeries were excluded from the study. So we have 40 patients between 2004 and 2018 with moderate and advanced hip osteoarthritis by Tonnes classification. The first group is group A, the osteotomy group, and the group B is the total hip arthroplasty group. In group A, osteotomy group, the osteotomy first the approach was the classic lateral approach. The osteotomy was oblique to enhance the stability, as we see. Also, it enhances the union and facilitates the bone union. DHS fixation was the implant of choice. The patient was non-weight bearing for 4 weeks, then gradual weight bearing. In the group B, the total hip arthroplasty group, the approach was direct lateral hard-hinge approach, cementless ceramic on polyethylene with early assisted ambulation. In the evaluation, we have considered the operative time and the blood loss, the Harris hip score before and post-operative, range of motion variables, and the Japanese Orthopedic Association Hip Disease Evaluation Questionnaire. This questionnaire has 3 variables, including first pain and movement, and the mental element of pain, the mental element, like anxiety, the degree of the patient's satisfaction, how the patient considers this his hip problem is stressful for his life. So it is characteristic with the mental element of pain. Also, the full score is 84. So most of our cases had a score of about 70 and more. So it was very good for us. In group A, osteotomy group, the operative time was significantly less than the group B and with less operative blood loss. In the group B, the total hip arthroplasty group, there was significant improvement in adduction and non-significant better patient-reported outcome in the questionnaire. Both groups had significant functional gains in Harris hip score and the non-significant improvement in all range of motion variables, as we will mention in cases. The limb length difference was comparable in both groups. We have many cases. The first one is a 30-year-old male patient with right hip moderate osteoarthritis. Osteotomy done with DHS fixation. The Harris hip score had improved from 60 pre-operative to 90 at 2 years post-operative. The range of motion increased by 5 to 10 degrees in all planes, and the Japanese questionnaire was 75. Case number 2, a male patient, 20 years old, with left hip advanced osteoarthritis. Osteotomy with DHS fixation was done. The Harris hip score had improved from 60 to 90 post-operative. The range of motion had increased by 5 to 10 degrees in all planes. The Japanese questionnaire was 78. This video, the patient sent to us from gym, as we see. Case number 3, a 20-year-old male patient with right hip advanced osteoarthritis. Osteotomy with DHS fixation was done. The Harris hip score had improved to 89. The range of motion variables had increased by 15 degrees in all planes. The Japanese questionnaire was 73. Case number 4, 35 years female with left hip moderate osteoarthritis. Osteotomy was done with DHS fixation. The Harris hip score improved to 92, and the range of motion increased by 15 degrees on all planes. And the Japanese questionnaire was 76. This is a simple video, post-operative, after 2 years. Case number 5, a 35-year male patient with left hip advanced osteoarthritis. Osteotomy with DHS fixation. And the Harris hip score had improved from 50 to 80 post-operative. Range of motion increased by 10 degrees in all planes, and the Japanese questionnaire was 68. To summarize, we want to say that subtrochanteric valgus osteotomy appear to be a good treatment option for high-demand young patient with hip osteoarthritis. This may have special value in circumstances with low income, in developed countries with low socioeconomic issues. Greater effort should be made to preserve the hip joint. Thank you.
Thank you very much. Can I ask you, what was the reoperation rate in the 5 years reoperation rate apart from operations for infection?
Infection?
لا, apart from infection, يعني if you put infection aside, what was your reoperation rate? يعني عملت عمليات تانية في خلال أول 5 سنين بخلاف drainage of infection؟ عملت اي عمليات للحالات ديت؟ لا لا. هل اضطريت تعمل arthroplasty in the first 5 years؟
We said that in the limitation of the study, we need a longer follow-up.
تمام.
Until now, no cases
No
required
case.
revision.
Okay, and now how do you solve the problem that eventually this patient will need a hip arthroplasty? This is a young patient. How are you going to solve the problem of doing a total hip replacement in the future when the proximal femur anatomy is being disturbed or altered? What do you suggest? Because you're a young chap and the patient will chase you, and one day he will knock on the clinic and come in and he says, I want a total hip replacement.
Yes, in the discussion chapter in our study, we have mentioned many literature and many studies that
Yeah.
concluded there is no problems with future total hip as regards the osteotomy.
All right. Do you need to undo the osteotomy and restore anatomy, or you can do total hip in the presence of an osteotomy and displacement on this patient?
Said that we didn't need any adjustment for the osteotomy.
Okay, so you can do a total hip replacement. You can put stem in the presence of the alteration in the anatomy of the proximal femur, right? Okay, thank you very much. Now it gives us great pleasure to introduce Dr. Khalaf Musa from Germany, and he's going to talk about the total joint replacement of the base of the thumb. This is a very common problem. دكتور موسى موجود؟ دكتور خلاف موسى؟ طيب موجود؟ اتفضل دكتور خلاف. دكتور خلاف موسى مش موجود. طيب all right, okay, so we're going to move now to Dr. Mohammed Hashim from the UK. He's next on the list. دول اللي حطوا presentation. الدكتور, okay, let's ask Dr. Ziad Al-Minnawi. He's a trauma and orthopedic surgeon in the UK, and he works in Dorset, which is a very posh place, and it's University Hospital. He's going to talk to us about the 2D versus 3D markers in hip templating, systematic review and meta-analysis.
Hello, good morning everyone, ladies and gentlemen. Thank you very much for having me today present this topic, talking about 2D versus 3D templating, mainly for total hip arthroplasty, comparing those techniques and their accuracy, really about measuring your prosthesis beforehand and taking part in surgical planning and making sure that you get good outcomes. So I'm Mr. Ziad Al-Minnawi. I'm working in the UK as a trauma and orthopedic registrar in University Hospital of Dorset. I've had the pleasure to be provided this opportunity by my dear colleague, Mr. Mohammed Hashim, who is part of this project as well. So this is a systematic review and meta-analysis that spans around approximately 5 to 6 RCTs from 2012 up to 2024. And it was published in the Orthopedic Proceedings of Bone and Joint Journal in March 2025. And this abstract was also presented in the British Hip Society meeting in 2025. So quite a recent paper. So today I'll be giving you a quick glimpse of the project, talking about its insights and also about the future of where it can go as well. So as hip surgeons, outcomes are very, very important for us, and also as orthopedic surgeons. Orthopedic surgeons are surgeons of function, patient function. That's the main goal of why we do our operations in the first place, to get patients up and moving. So that doesn't make anything second of giving importance and priority to our preoperative planning, which not only includes the templating and looking at the prosthesis size, the femoral component, the acetabular components, risk of where can this take us with risk of failures, but also looking at the patient as a whole, which plays a big role in those fine tunings that helps us take us to the next level of having better surgical outcomes and patient satisfaction and experience as well, and definitely reducing any kind of financial burden on your trusts or on your hospitals. So we'll have to make sure that our implants are of correct size and position, and appreciating preoperative planning. Why do we do preoperative planning? Again, because it's very important for efficiency. As per the national standards in the UK, they get it right the first time girthed. which mainly focuses on increased efficiency, lowering costs, and lowering infection as well, in order to help streamline medical service and prevent patient burden and financial burdens on several organizations. And this will definitely also help reduce any medical legal consequences that you might face. And it also shows that as a surgeon, you're more aware of the case. You've done a proper planning. You've thought about all the patient factors in order to help you have a correct templating for your operation. So doing this preoperative templating is important to restore the hip biomechanics, reducing the complications, improving implant longevity, also improving patient experience. So this study mainly looks at the sizing of the femoral stem and acetabular component, acetabular cup, comparing 2D and 3D techniques and which one is better. So a quick overview, what is 2D and 3D templating? Well, 2D is more of the traditional way where you have x-rays, where you can use just like the old days, the gray transparent paper, and you can draw a sketch in order to have correct measurements. But now we do have some softwares that have been introduced that give you a full 3D immersive view of the joint from several cuts, coronal, sagittal, and axials, and also gives you 3D recons. I'm sure most of you might say there is a clear winner of which one is better, but let's have a deeper look. Looking at the methods, so papers were extracted mainly from PubMed, Medline, Embase, where we've had a total of 1,424. And using Prisma guidelines, these were filtered out to have a final of 9 papers. And out of these 9 papers, we've applied the RUP2 for RCTs and also the minors criteria to look into bias for non-RCT papers. So out of the total 9 studies, there were 798 hips screened in these papers, again, spanning from 2012 up to 2024. And the mean patient age was 66, which is more of bang on the usual age where we do hip replacements, where patients start complaining of osteoarthritis and having more degeneration and need some surgical intervention. So looking at the results, comparing between the 3D and the 2D templating methods for the femoral and acetabular components. So of course, the 3D showed increased efficiency and accuracy in measuring these components compared to the 3D, which we'll be explaining in more detail, that given that the 3D has a more three-dimensional view using CT scans where you have different recons, gives you that higher leverage of being able to have a closer look and a more thorough look of that joint before proceeding with your operation and having accurate templating. So what are the main limitations? Well, we won't be able to do CT scans for every single patient before the operation. Sometimes you need just an X-ray where you can sort of judge your decision based on that. And it's not going to be an efficient matter of exposing patients to radiation, increasing costs on the trusts and your hospitals to keep doing CT scans for everyone. So I think for future recommendations, we'd rather focus on using it just for maybe revision surgeries or more complex operations where that extra bit of minute detail plays a big difference, or maybe for patients with slightly more complex backgrounds or medical comorbidities. And of course, there aren't enough studies about whether this improves patient outcomes long term, so future research should definitely more focus on that aspect about this 3D templating, given that it's more accurate. Does that help increase patient outcomes and functionality? Or if we still use the 2D, would there not be a significant difference? And of course, having to do CT for everyone, that delays surgeries, having to let patients wait, getting a slot, and maybe having to repeat the scans again if you didn't get the result that you want. So it's definitely a lot of burdens that needs to be taken into consideration. So about future directions, as I alluded to earlier, that future studies need to be more focused into outcomes, of patient outcomes, given these differences in templating and which one is more accurate. And additionally, seeing that whether we can imply this just on a specific cohort of patients that would significantly benefit from this decision of having them to have 3D recons and CT scans for preoperative planning. So in conclusion, the findings that show that the 3D templating is definitely more accurate than the 2D templated. I'm aware that here not all hospitals would have that privilege of having to get 3D constructs and have a software where they can do those for those patients. But of course, that's something that would be generally recommended in order, again, to increase efficiency, patient experience, and functional outcomes. Thank you very much.
Right. Thank you very much for your presentation. I'd just like to ask you, do you template in your hospital?
Yes.
And how do you do it on the PACS 2D or on the CT 3D?
Yes, so we usually use it on the PACS. There is an additionally installed software inside of it called EOS. So every trust is different, where you can use those templates. Oh, apologies. Can you hear me?
Yeah.
So yes, we do use the templating in trust. Every trust have some kind of different software, so it's not generalized over several hospitals. But yes, for example, in PACS, there is a templating option where you can use those 3D reconstructions in order to template your surgeries.
Right, but as you mentioned, there's, first of all, the 2D templating on the PACS is more accurate than plain X-rays because it's reduced or increased to proportion, and you can detect the distances and measure diameters. The other thing that the CT not only a high exposure, but the burden on the hospital.
Yes.
You would possibly do between 50 and 100 hips a year or more.
Absolutely.
It will block the radiology department. So perhaps for the majority, they can template on 2D on the PACS screen rather than on doing a CT for everyone. And for complicated cases like dysplasias or deformities of the proximal femur, like we've just seen in cases of previous osteotomy or previous proximal femoral fractures, then you would selectively use those for 3D.
Absolutely, and that's definitely something that needs to be given more consideration in the future, where we will have to have selective cases in order, again, to reduce that burden. And the 2D templating that can be done on PACS as well in many different softwares are pretty accurate, but of course 3D just gives you that extra leverage. But yeah, I second you on it not being applicable to just everyone that's going for a hip replacement.
Right. I think in the future there will be software in AI which you give them the X-ray picture from PACS,
yes,
and you give them the dimensions of the different implants components, and he'll do it for you and advise you about the appropriate size and implant, and you can then recheck on it.
Absolutely.
Thank you very much.
No worries, pleasure. Thank you very much.
Now, another important topic, are routine post-operative blood tests necessary after primary total joint replacement by Dr. Mahmoud Abdallah from Sherwood Forest Hospital, and that's where Robin Hood is. We routinely do full blood count every second day, and then if the patient is anemic, less than 10, we might be forced or tempted to transfuse, and this is a burden because transfusion will increase the risk of infection in total hip replacement.
Good morning, everyone. Assalamu alaikum for everyone. My name is Mahmoud Abdallah. I'm working in Sherwood Forest Hospital. I'm one of orthopedic registrars there. We're talking today about our routine post-operative blood test is necessary after primary total joint replacement. The main aim for this study really is to answer the question for that title, and I think most importantly is to find out if there is any way to predict which patient that might need post-operative blood or not. I think we rely in our study mainly on ASA grade. It's American Society of Anesthesia grade assessment. Every one of us knows this grade. I think if we manage to avoid the unnecessary post-operative bloods, I think this will be bonus in many ways. We will reduce the unnecessary tests, like Dr. Khalid said. We will shorten the hospital stays, lower cost, and I think we are shifting massively now in UK to do the day case joint replacement. Our study, it's a retrospective study. We just finished the first 1,200 patients. Our plan is to look to 4,000 patients, but this is the patients that we finished so far. And we collected the data from our electronic patient record. We looked to the age, sex, BMI, which joint replacement is a TKA or a total hip replacement, and definitely the ASA grade, and both pre-operative and post-operative blood test result. And we record any intervention we have done, including management of AKI or any electrolyte imbalance or blood transfusion. This is a table, this is a complex table, show all the data. But this is the main thing. Most of the total hip or total knee patients, they usually fall either in an AC2 or AC3. So we found that 51% of our patients so far is an AC2 and 40% is an AC3. Our result, we found a statistically significant correlation between the needs of post-operative intervention and higher ASA grade, pre-op anemia, chronic DWAC use, and serum sodium level. From 1,200 patients, 43 patients needed intervention, 17 for post-operative anemia. 10 of these 17 needed blood transfusion. The interesting thing about these 10 patients that they need a blood transfusion, we found that 90% of them, so 9 patients of these 10, they had a pre-operative anemia, and the HB was less than 120. And then we managed 7 with iron therapy and active monitoring. And then we found that 24 patients of these 43, they had the hyponatremia, and 23 are asymptomatic, and we just did the active monitoring, and we asked the GB to look with the routine bloods for them, and only 1 patient of these 24 patients had symptomatic hyponatremia with a confusion, and we had to do a fluid restriction. We had to call our medical team to do some intervention to correct that. And we have 2 patients had acute kidney injury, and again they treated with IV fluid and stop of the diuretic and asked for the medical team help. Interesting bit that we found that all our patients that they needed intervention, they were ASA grade 3 and 4. And no single patient of ASA 1 and ASA 2 needed any intervention or had any post-operative blood change. Another interesting bit, post-operative HemiQ. I think in our trust, we started last year to do a HemiQ in the recovery for every single patient after total hip and total knee. But most of the surgeons in our trust are not yet convinced much about the rule of HemiQ. So I had a chance to look to the HemiQ and the post-operative hemoglobin at the same time and compare. And it's so reliable. It is any patient had his HemiQ was more than 100 grams per liter. He showed a normal hemoglobin level, and he does not need any intervention. I think this is graph. This is show what the patient numbers. This is the tables for the numbers and what treatments they had. I think our recommendation that patient with ASA grade 1 and 2 does not typically require post-operative blood test, and patient with ASA grade 3 and 4 at an increased risk of post-operative complication include anemia, electrolyte imbalance, acute kidney injury, and we need to continue to undergo a routine post-operative blood testing for them. I think especially the people with chronic kidney disease, most of these people developed post-operative hyponatremia, and 2 of them developed a acute kidney injury. I think we need to start to rely now more on the HemiQ. It is a simple test. We can do like the blood sugar. It is so cheap. We can do it in our recovery, and any patient has HemiQ is more than 100 grams per liter. That reliably exclude any clinically significant anemia, and then we don't need to do a full blood count for those patients. And I think preoperative hemoglobin level less than 120 are associated with higher likelihood of postoperative transfusion. So I think those patients need a lot of optimization, and we shouldn't go to the theater with them unless they are 120 or more. Thank you very much. Any question?
Yeah, thank you very much, Dr. Mahmoud. Could you just explain to us what is a HemoCure test and what does it detect?
So it is a simple test. It's like the blood sugars that we use. It is like a strip, and
Yeah.
you just puncture the patient, and you have that on the machine,
Yeah.
on the small machine, like the blood sugar, and then you will see the reading. So it's
All right,
so
and the
simple.
reading is the hemoglobin content of the blood?
No, it's not a hemoglobin.
What is it? What's the reading? What does it tell us?
So I'm not very sure about what is the HemoQ,
Okay.
or how it is measured, but it is something quite relevant to the hemoglobin of the patient.
All right, and you do it in the recovery room or the next day, or
No,
both
in the recovery.
in the recovery?
In the recovery. So once the patient finishes his operation, you just small punctures, get the numbers for the HemoQ. And now we have few surgeons that they start to rely on it mainly. If the HemoQ is more than 100, they don't do any full blood count, and they don't do any routine postoperative blood.
All right, in your hospital, do you use the cell saver intraoperatively, or
Sorry?
do you use the cell saver in your hospital intraoperatively?
Yeah, but we use only the cell saver for revision case or periprostatic case. If we go to do a revision case for periprostatic or a revision for a primary, we use the cell saver, but we don't use the cell saver as a routine for the primary case. And our studies mainly look in the primary joint replacement.
Right, do you use a post-operative autologous blood transfusion from a drain, or you don't use drains? What's your
No, we don't use
what's
a
your,
drain.
you don't
use
use
a drain.
drains?
We only have one surgeon that he uses a drain for
Okay.
his total knee replacement. But I think, this is no longer a favorite trend in the UK to use a drain for total knee replacement. But for sure, the total hip, we don't use a drain.
Right. You touched on very important points like hyponatremia and acute knee injury, which we all want to avoid. But thankfully, our patients are not starved for a long time, and within 6 hours, you can resume eating and drinking. However, this hyponatremia, the elderly patients and the ESA grades 3 and 4 are very sensitive to it. So as you mentioned, perhaps we need to screen next day whether they are hyponatremic or not, because they can slip into brain confusion in the hospital or when they go back home. Thank you very much, Dr. Mahmoud.
Sure, okay. Thank you.
Now then, we call on Dr. Mohammed Hashim. He does trauma and orthopedics in the UK. I think Frimley Park, is it, or somewhere else? Frimley Park, all right, okay. He's going to talk to us about the impact of a 24-hour enhanced recovery protocol on length of stay and outcome in elective arthroplasty. It is a comparative study. There are many people, many surgeons across the continent and across the Atlantic are actually adopting the concept of a day surgery knee and hip replacement.
Yes. Thanks, Mr. Chairman, and good morning, everyone. So I'm an orthopedic consultant in the UK, Northwest London, Family Health. So I'm speaking today about the impact of the Enhanced Recovery Protocol. So the Enhanced Recovery Protocol is based from the GIRFT accreditation for any center, for any elective hub in the UK. And to apply it, you need to be sure it's safe and reliable. So I don't have any disclosure to this related to this topic. And basically, as an introduction, we understand that aging process is going more and more, and so we have more and more cases with osteoarthritis which need an arthroplasty. Total knee replacement today is the most common orthopedic procedure in the statistics. So from all the registries, we can see that the numbers are going up and up, and it's expected to go more and more higher with the time. In the UK, in the 2023, there was 116,000 primary knee replacement performed. 98% of them were osteoarthritis. So in the literature, the average length of stay for a hip is 1.2 days, and definitely is more than this for the knees. And Enhanced Recovery Protocol is not something new, it's already there from before, and there were a lot of trials to implement this in different hospitals, and the problem was about, is it safe or not? In 2023, we start to apply the enhanced recovery protocol in order to get the accreditation from the GIRFT as a high-volume, low-complexity center in our new elective hub in Heatherwood Hospital. And our aim from this study was to ensure that we were able to reduce the length of stay by this protocol while we're maintaining a good outcomes and avoiding any post-operative complications. The main complications we were looking into was the revisions and readmissions. So we conducted this unicentric study in our Heatherwood Hospital. It's a retrospective. We looked into a cohort before application of the protocol and a cohort after application of the protocol. So our exclusion criteria was any arthroplasty for any reason rather than osteoarthritis. So we're dealing with primary arthritis for arthroplasty for an arthritis. Collect every data, so all the patient demographics, AC grading, the surgical procedure, and any individual pre-operative management. So the enhanced recovery protocol we applied, very simple protocol based on an evidence-based approach we just presented yesterday. So pre-operatively, we optimize our patient in the clinic. We have a pre-assessment clinic. We have a special patient education team. Patient got assessed by the anesthesia and ensure that this patient is okay for a spinal anesthesia. Especially we use a very short-term spinal anesthesia. We avoid using long-term spinal anesthesia anymore. On the day of admission, we apply staggering protocol. So the patient for the morning list comes at 7 a.m., while the patient for the afternoon list comes at 11 a.m. So we ensure shorter hospital stay for the patient. We do a physiotherapy assessment, ensuring that this patient will be mobile post-operatively, and we ensure that the patient have a slot for post-operative X-rays. Operatively, so we change the whole protocol. So patient comes walking to the theater, and we use a Prilocaine short-acting anesthesia, gives you like a couple of hours operative time. We stop using any motor nerve blocks. We stop using tourniquets. We don't use any drains. We use systemic TXA, and we use local TXA as well into the wound. We don't use any post-operative antibiotics. It's only a stat dose on induction. Post-operatively, the patient starts to eat and drink from the recovery. We try to mobilize them once the anesthesia is off, and the physiotherapist review them in the mobilization to ensure they are safe. Once they are mobile, we complete an X-ray, give a patient a full explaining leaflet for discharge, and we give them we have a specialized nurse for arthroplasty which follow them up in 72 hours virtually through a phone call. The primary outcome was the 30 days post-surgery readmissions, and secondary outcomes were length of stay, post-operative complications, and revision surgeries. Complication, we mainly looked into the superficial surgical site infection, the dislocations, and the VT events. So big cohort, so nearly 1,000 before and 1,000 after. So most of them are females, which is not surprisingly, and the mean age was about 70 years old, and it's comparable in both cohorts. AC grading again was comparable between both cohorts, giving a consistent results. And the arthroplasty type, again, it's not a surprise to know that the knee was the most commonly procedure done, but we compared all the arthroplasties, including shoulder, ankle, and we revisions, but we excluded revision from the final results. So the results did show that we really achieved what we aimed for. So length of stay reduced in average by about half a day for a hip cases and about 1.5 days for the knee cases. We were able to achieve a same-day discharge, which is same day means 24 hours, not the same calendar day. And this was achievable by 5% in the second cycle compared to 2.9 in the first cycle. Longest length of stay, single patient in every cohort, and this was mainly for medical reasons. And there was no inpatient mortality. There is only one patient who died in the second cycle, and this was from aspiration pneumonia. This was a very frail patient in a care home. The 30 days hospital readmission, it wasn't surprisingly, it increased from 6 cases to 26 cases. The good thing about that 12 of them were just a surgical site infection, superficial surgical site infection. And the other admissions were mainly knee cases coming for pain, and this admission was only to the ED. So in the UK, the readmission is from the ED. Joint washout it increased from 3 cases to 9 cases. Comparing the 2 cohorts, this wasn't statistically significant. We have 2 events of pulmonary embolism in the second cycle, and we achieved the cost saving of about £110,000 in 6 months. So from a discussion point of view, after we introduced this protocol in 23, all the 110,000 patients, 1,010 and 114 patients in the second cycle has achieved a successful operation and was safely discharged. Post-operative length of stay was reduced by 0.31 days. In average, this was statistically significant. There was no recorded inpatient mortalities. There was no significant increase in 30 days readmission from statistical point of view, and even from clinical point of view, as most of the readmissions were between pain or superficial site infection. There was no significant increase in the complication we were looking into between the two cycles. We achieved the cost saving of about £110,000 in 6 months. This was calculated based on the cost of admission, which came from the increased readmission, compared to the total cost. So even calculating the cost of the increasing readmission, we still was saving about £110,000 in 6 months. The limitation of this study is only our unit, so it's a single unit study. It's retrospective. We looked into this patient retrospectively. The follow-up period, because we were aiming to see the increase of early complication, was only 1 month. So to conclude from this study, we can say that reduced length of stay or achieving a single day or a same-day arthroplasty can be safely achieved, and this, according to the enhanced recovery protocol. The shortened hospital admission always allow for rapid patient recovery, which alleviating any financial pressures, and analysis of data from multi-centers with longer follow-up is definitely advisable. So this is the references, and thank you so much.
Thank you very much, Dr. Hashim. The significant money you saved, is that over annually, every year, or calculated over a 2-3 years period?
No, so this was 6 months cohort before and after the protocol.
A 6 month saving of 110,000 English pounds.
Yes.
Right, that's
calculating the readmission, because the readmission has increased the cost a bit.
Okay.
But even after the readmission, we saved the 110,000.
Right. How you justify that in the second cycle you had a high percentage of infections? Yeah, it was 0.4, then it went up to 1.1. How do you explain it?
Yeah, the problem was mainly with the knee cases. So post-operative swelling and pain. And when the patient is discharged a bit early, a bit of hematoma, we don't use any tourniquets, and we don't use drains. So if the patient is discharged early, there is a bit of increased swelling and edema, and so there is a risk of infection. Most of these cases were knee cases, and they come with superficial wound infection. You know, you was before there, Dr. Khalid, and you know that they are frail patients, and if they don't go straight away for activity, they don't have enough care, they very easily comes back with superficial infection. The good thing, none of these needed a deeper debridement except 3 cases from a cohort of about 1,200. So 3 cases only who needed a washout. None of them needs a revision or any more intervention.
All right. Thank you very much for the study you
thanks.
presented, and you've made significant difference and savings to our hospital. Thank you very much, Dr. Hashim. Have you got any more presentation? في حد تاني يقدم؟ خلاص؟ طيب. We still got almost 10 minutes, so we open the discussion for the floor. Anybody would like to ask any question to any of the presenters? They're all interesting cases. We've seen decreasing the number of the number of days staying in the hospital, post-op complications, anemia, hyponatremia, etc. So anybody would like to ask any questions from the audience? Fadl.
Does it fair comparing total hip, total knee, and shoulder arthroplasty for 1 day admissions?
Very valid point, to be honest. So the worst is the knee, the best is the shoulder. But the point is we were looking into the whole cohort because we have to approve for the graph that the enhanced recovery protocol is working. But I think if a proper study is planned, I think it should be planned hip alone, knee alone, looking into, because if we get the knee out of the equation, the results are marvelous. The problem, if the knee patient is always painful, it's always swollen, it's very high risk to get a superficial infection. But it's a very valid point, and should be added to the limitation of this study. Yeah, thank you so much.
question for the first speaker about the type of prosthesis used if you want to make total hip after valgus osteotomy. Is it standard prosthesis or custom made? Standard. Yes. Thank you.
In the majority of cases, you don't need special prosthesis, but they will eventually need a hip replacement in 10, 15, 20 years, except in cases in which there is severe deformity, in which you need to undo, break, fix, and then replace when it's healed. Is there anything you'd like to add?
I think in the future we have a lot of things, but he opened a new windows because we are mainly minded by arthroplasty for all the patient. And we found some people who's 18 years, 20 years, and somebody advised him for a total hip. But this is a good option. And if you give a longevity for this patient, whatever, until he started to complain, then we think in the future. But I think by the time we have a personal, what we call another companies, or companies can provide us with a solution. And we have also trochanteric osteotomy, and we have extension osteotomy, and you have a lot of things we can do it as a primary total hip for this patient.
I quite agree. This was published in a book of Bombelli, the valgus extension osteotomy, and how it works to pull up the osteophytes, make them overgrow, and cover with cartilage to overcover the femoral head, and he had fantastic results. The only thing we have to put in mind that we have to be prepared for revision to hip replacement in the future. Perhaps I might not see it in my age, but he's younger, and they will chase him 10 to 15, 20 years later. The other option is that the Western patient does not accept osteotomy and does not accept the arthrodesis. They want to get a hip replacement straight away to improve the quality of life. They don't want to wait till the osteophytes grow and the joint covering of the cartilage increase in thickness, and they don't want to. They don't want to do. They want a hip replacement. They can resume their activities of daily living, and they're not very much concerned about the long-term risk of revision. And the surgeons are not either, because they get the expertise and the equipment. Any other questions to all presentations today? Right, thank you much, everybody. We'll move on to next session as scheduled in the timetable. Thank you.